Thank you so much, Christen, for that detailed overview of our local approach as it relates to lower limb preservation. It's incredibly valuable to see how structured risk-based care can make such a meaningful difference on the ground. Now pleased to introduce our next speaker, Dr. John Coates. Dr. Coates is the physician champion for our local lower limb preservation strategy and someone who brings not only clinical expertise, but a deep personal commitment to improvement outcomes to the space. He's seen firsthand the dramatic implications of limb loss on patients and families, and he has been a driving force behind building more proactive, collaborative models of care in our region. So please join me in welcoming Dr. Coates.
Thanks, Harrison. Note that today's webinar is quite timely because April is Limb Loss and Limb Difference Awareness Month. And this slide shows some pictures of my little sister, Melissa Coates. She was an internationally renowned bodybuilding champion and pro wrestler who lost her left leg in October 2020 due to blood clots in the arteries causing acute limb ischemia. We believe a COVID-19 infection caused a hypercoagulable state. Sadly, her condition was not recognized and treated soon enough, and she required an above-knee amputation. She passed away unexpectedly 8 months later with her autopsy showing a cardiomyopathy and peripheral arterial disease. My sister's experience with limb loss has inspired me to become involved in the lower limb preservation strategy. Next slide. Now I will be speaking about complications of the diabetic foot. Next slide. The most important complication of the diabetic foot is peripheral neuropathy. The lifetime prevalence in patients with diabetes is 50%. Peripheral nerve dysfunction occurs due to both metabolic and vascular factors in the setting of chronic hyperglycemia. Symmetric polyneuropathy characterized by pain and paresthesia, or it may be asymptomatic, along with sensory, motor, and autonomic deficits. Sensory neuropathy leads to loss of proprioception, pain and temperature sensation, loss of protective sensation or LOPS, which predisposes to unrecognized minor trauma and contributes to abnormal gait. The motor neuropathy causes muscle wasting, mainly affecting the extensor muscles. This results in flexor-extensor imbalance, leading to foot deformities such as equinus deformity and clawed toes, abnormal gait, and abnormal pressure distribution that creates new pressure points at risk for ulceration. Autonomic neuropathy results in reduced sweating, which causes dry, fragile skin prone to cracking, reduced sympathetic nerve-induced vasoconstriction, and microvascular dysregulation of the skin that contributes to local edema and impaired healing. Next slide. Diabetic foot ulcers. As you know, ulcers are open sores on the body caused by broken skin that fails to heal. Diabetic foot ulcers are a frequent complication, and the lifetime risk in diabetic patients is 25%. Risk factors for foot ulceration in diabetics include peripheral neuropathy, associated foot deformities, resultant trauma, as well as peripheral arterial disease. Next slide. This diagram illustrates the factors that lead to diabetic foot ulcers. These include an interplay of neuropathy, motor, sensory, and autonomic, as well as angiopathy, both micro and macro, i.e. peripheral arterial disease. Next slide. This diagram illustrates the factors of a person at risk, including risk factors like associated pathologies like retinopathy, cardiovascular disease, kidney disease, lifestyle factors such as smoking, inactivity, and then the localized risk factors in the foot, including the foot deformities. Next slide. This illustrates the location of diabetic foot ulcers due to the most common foot deformities, which are caused by the motor neuropathy. Next slide. Charcot foot is a rare but more severe condition. Charcot neuropathy is a rare inflammatory disease involving the musculoskeletal system of the foot and ankle caused by an inability to sense injuries. The disease process ultimately results in deformity of the foot or ankle due to collapse, fracture, and destruction of structures under significant pressure. Once this occurs, the foot will be altered for the rest of the person's life and at very high risk for ulceration and amputation. Conventional footwear will lead to further damage, and treatment requires offloading with total contact casts or special boots such as the Crow boot, Charcot restraint orthotic walker. Early signs of Charcot include a painful foot that is hotter and redder than the other. Next slide. Common misdiagnoses of acute Charcot foot include inflammatory conditions such as gout, pseudogout, infections such as cellulitis, septic arthritis, osteomyelitis, and other conditions such as DVT, sprains, strains, or fractures. Next slide. This slide shows some dramatic photos and x-rays of a Charcot foot with a diabetic foot ulcer. The x-ray shows multiple fractures and misalignment of the bone fragments. Next slide. The location of a lower limb ulcer can give you a clue as to the etiology. Venous ulcers, due to venous insufficiency, venous hypertension, and compromised circulation to the skin, commonly occur on the lateral aspects of the lower leg just above the malleolus. Also, quite often, patients with venous insufficiency develop severe edema with weeping of clear or serous fluid, lymphoria, complicated by cellulitis and skin breakdown. Neuropathic ulcers, most commonly due to diabetic peripheral neuropathy, tend to occur over pressure points on the foot and ankle. Arterial ulcers, due to severe PAD or peripheral arterial disease, occur over the same areas as diabetic neuropathic ulcers, but may also occur over the shin. Next slide. Another major complication of the diabetic foot is wound infections and osteomyelitis. Diabetic foot infection usually occurs as cellulitis, deep skin and soft tissue infections, acute or chronic osteomyelitis. Cultures should only be taken from clinically infected wounds, the most common organisms being Staph aureus, Streptococcus, and Pseudomonas. Next slide. Diabetic osteomyelitis. This should be suspected in patients with a prolonged or recurrent ulcer, a deep ulcer, especially if it probes to bone, difficult to heal ulcer greater than 2 months despite optimal treatment. X-ray may not diagnose in the early stages, and you might need to do a bone scan or possibly an MRI if you're concerned. The bone scan on the left shows increased uptake, indicating increased blood flow and increased bone metabolism at the area affected by osteomyelitis. X-rays show soft tissue swelling, periosteal reactions, and bone destruction. Next slide. Sepsis should be suspected in patients with infected diabetic foot ulcers who have systemic symptoms such as fever, rigors, chills, and hypotension. This can result in multi-organ failure and death. And not to be forgotten are mycotic infections such as tinea pedis and onychomycosis, as these can cause skin breakdown, impair wound healing, and increase the risk of bacterial infections. Next slide. The Nerds and Stonies mnemonics developed by Sabalbal et al. Are memory aids used to identify and differentiate between superficial bacterial damage, NERDs, and deep worsening and surrounding skin infection in chronic wounds, Stonies, and they help guide management. Superficial infections are treated with topical antimicrobials such as iodine and silver-based ointments, dressings. Deep infections are treated with oral or IV antibiotics. So in NERDs, for superficial infections, the wound is non-healing, there is exudate present, red friable tissue, which may be bleeding, there's debris, and there may be a foul odor. As the wound worsens, the size increases, temperature around the wound increases. The bone may be exposed, or you may be able to probe to bone. There's new breakdown around the ulcer, increased exudate, redness and swelling, and worsening of odor. Next slide. So this is the nerds and stonies in a little bit more detail with some photographs. The N, we should be vigilant of wounds that appear to be non-healing, typically do not respond well despite ongoing treatment and/or antimicrobial therapies. E, exudative wound, pay attention to an increase in or change in characteristics of the exudate, often clear in stages of healing and non-infection, but may become purulent or sanguineous once infected. Encourage use of appropriate protective ointments, dressings to shield the peri-wound surrounding skin barrier. Increase in exudate should alert you to further investigate for signs of infection. R, red and bleeding wound. Take note of the wound bed itself and whether or not granulation tissue is pink and firm, non-infected. Excessive bleeding may indicate bacterial damage within the infected vasculature of the tissue. Next slide. D, debris in the wound. Necrotic tissue will require either chemical or surgical debridement and follow-up care. Debridement to be determined based off of staging, severity of wound, expertise of clinician, and resources available. S, take note of any foul or putrid odor indicative of wound-related bacterial infection. Note that odor may arise from both superficial and deep tissue damage. Next slide. As infection spreads to deeper and surrounding tissues, the Stoney's mnemonic is helpful. S, size is bigger. In a wound that continues to worsen, size may increase. Take note of initial size and depth of wound and continue to monitor for changes. T, temperature increase. Surrounding skin of the wound may have increased warmth, which may be detected by touch or by infrared thermometer. They're also using infrared or thermal cameras. Next slide. O, os, probes to or exposed bone. As the infection spreads deeper, the wound may probe to bone, or the bone may be visible. It is likely that osteomyelitis is present. N, as the wound worsens, you may see new areas of skin breakdown. Next slide. E, exudate, erythema, and edema. Again, with an increase in severity of infection, often to the deeper tissues, wound exudate will change from clear serous to purulent. Erythema and edema will increase as well. And finally, S, standing for smell, odor generally becomes more foul with more severe infections. Next slide. There are several classification systems used to risk stratify diabetic foot wounds. The 2023 guideline of the International Working Group of the Diabetic Foot presents a classification symptom of infection severity ranging from 1, uninfected, through to stage 4, severe infection, which can include sepsis and osteomyelitis. And the slide shows this classification. Next slide. The International Working Group of the Diabetic Foot also presents recommendations for choice, route, and duration of antibiotic regimen related to severity of infection and type of bacteria. Next slide. This is a helpful mnemonic, I believe also developed by Dr. Sibbald. Management of diabetic foot ulcers, you can remember the VIPs. V stands for vascular supply, i.e. pedal pulses should be assessed. I stands for infection, which should be diagnosed and treated if present. P stands for pressure. Be sure the patient offloads the wound as it won't heal if subjected to continued pressure or trauma. S stands for surgical debridement, which these wounds often require, generally done by a wound care nurse or a vascular surgeon. Next slide. Given my sister's awful experience with peripheral arterial disease, I have prepared some slides regarding peripheral arterial disease, or PAD. PAD is atherosclerosis affecting the peripheral arteries, which may cause stenosis or occlusion of the arteries. PAD is very prevalent and has a high morbidity and mortality. 1 in 3 diabetics over age 50 have PAD. 1 in 5 adults over age 60 have PAD. It has an insidious onset, with most patients being initially asymptomatic. About 50% of people with PAD are asymptomatic, 40% present with intermittent claudication, and about 10% with chronic limb-threatening ischemia. Intermittent claudication is pain, heaviness, or cramping in the legs that occurs with walking the same distance and is relieved within 10 minutes of rest. Chronic limb-threatening ischemia, which used to be called critical limb ischemia, is severe progression of PAD with severely compromised blood flow to the leg. It presents with rest pain plus or minus a foot wound. This pain is generally defined to have been present for at least 2 weeks or more. A common physical finding in severe PAD is dependent rubor, where the affected foot may appear dusky red when it is held below heart level. Elevating the foot causes loss of color and worsens ischemic pain. 25% of patients with chronic limb-threatening ischemia require an amputation within 1 year. The mortality rate of intermittent claudication is 30% at 5 years. Chronic limb-threatening ischemia is 25% at 1 year and 60% at 5 years. This is higher than most types of cancer. Next slide. So the Edinburgh Claudication Questionnaire is a good screening tool to help figure out if leg pain is due to intermittent claudication. Answers to the questions in green should be yes. Answers to the questions in red should be no. So do you get pain or discomfort in your legs when you walk? That should be a yes. Does this pain ever begin when you're standing still or sitting? Is a no. Do you get it if you walk uphill or hurry? Do you get it when you walk at an ordinary pace on the level? Those should be yes answers. What happens to your pain if you stand still? With intermittent claudication, the pain disappears within 10 minutes or less. And where do you get this pain or discomfort? May help identify which arteries are compromised. Next slide. The ankle brachial pressure index is a quick, easy, and effective way to screen for peripheral arterial disease. It is calculated by dividing the ankle systolic blood pressure by the arm systolic blood pressure. One should be cautious, however, interpreting this test in patients with diabetes, chronic kidney disease, or extreme old age, as they are more likely to have calcified arteries that can cause a falsely normal or high ABI. The smaller arteries in the feet are less susceptible to calcification. In these cases, a toe brachial index, TBI, is helpful to rule out peripheral arterial disease below the calf. Arterial duplex ultrasound can also help diagnose PAD and determine the location of an arterial stenosis or occlusion. An ABI less than 0.9 indicates PAD, normal 1 to 1.4. Less than 0.7 usually causes intermittent claudication. Less than 0.4 is severe impairment of blood flow and is high risk for chronic limb-threatening ischemia. Next slide. Acute limb ischemia, which my little sister had, is a lesser-known vascular emergency due to an acute occlusive event in an artery, typically caused by thrombus or by embolus. This event may lead to irreversible ischemia, tissue death, permanent neuromuscular damage, and may require amputation. Patients with acute arterial occlusion usually present with some of the 6 Ps: pain, pallor, paresthesia, numbness and or loss of sensation, paralysis, a change in motor strength, pulselessness measured by palpation or handheld Doppler, perishingly cold poikilothermia, which is loss of temperature regulation. Acute limb ischemia pain is defined to have been present for less than 2 weeks. Next slide. Acute limb ischemia. Next slide. Acute limb ischemia carries a very high risk of morbidity and mortality. 20% of patients will require an amputation. The 30-day mortality rate is 10 to 15%, and the 1-year mortality rate is 40%. Suspected cases of ALI should be referred immediately to vascular surgery, as imaging prior to referral may delay limb-saving procedures. The golden window for limb salvage is considered to be 4 to 6 hours after symptom onset. Next slide. This Venn diagram shows the overlapping relationship of risk factors associated with non-traumatic limb loss in the United States. Estimates of total affected U.S. population, U.S. prevalence, and annual incidence rates are shown, so that there's that overlap of diabetes with PAD and peripheral neuropathy, resulting in foot ulcers and/or critical limb ischemia and limb loss. Next slide. I like this Venn diagram as well because it shows the various aspects of PAD, comprehensive wound care, that contribute to limb preservation. So we should be remembering that cardiovascular risk factors are optimally treated, such as high blood pressure, high cholesterol. They may require antithrombotic therapy as well as antiplatelet therapy, smoking cessation, good control of their blood sugars in patients with diabetes, and education about diabetic foot care, and excellent wound care and follow-up of the diabetic foot. Next slide. And that concludes my this section of my presentation today.
Thank you so much, Dr. Coates, for that important clinical perspective and for your leadership in shaping our local strategy. Your insight into the long-term impact of lower limb conditions is invaluable to this conversation. Now I'm pleased to introduce Harleen Sanghera. Harleen is a primary care nurse practitioner supporting the lower limb wound prevention and treatment clinic here in Windsor. As noted earlier, she works directly with a diverse population of clients, many of whom face complex medical and social challenges. Harleen brings deep expertise in clinical assessment, wound care, and patient education, and plays a vital role in our interprofessional team. Today, she'll walk us through the hands-on tools and assessments we use in practice, including the INLOS 60-foot screen, and other clinical approaches to managing lower limb health. Welcome, Harleen.
Thank you, Harrison. Hi, everyone. So today I'll be discussing and reviewing the various clinical practices and tools we implement when we assess clients that are referred to our lower limb preservation clinic. Next slide. So the INLOS diabetic foot screen is a 60-second tool that was designed to assess the risk of foot complication associated with individuals with diabetes. It helps identify early signs of diabetic foot issues, which if left untreated can lead to serious concerns such as ulcers, infections, and possible amputations. Each section of the foot screen has a different assessment. So at the top of the foot screen, we report any risk factors such as retinopathy or smoking just to get a better overall picture of the client. Then we perform skin assessments where we check for any cuts, blisters, sores, infections, calluses, and the nails for any ingrown toenails, thickened nails, or any signs of infection. Next, we perform a neurological assessment to check for peripheral neuropathy using a monofilament for testing. And this allows us to assess for any loss of sensation at specific sites on each foot, as you can see in the picture. If any of these are abnormal or the client cannot feel when monofilament is being used, this is considered loss of protective sensation. We then focus on doing a vascular assessment, asking if any symptoms of PAD are present, using either the Edinburgh Claudication Questionnaire, as Dr. Coates mentioned, or even asking, are you having any pain, any dependent rhubarb, or is there a cool foot on assessment? We also check for circulation in the feet, the posterior tibial and the dorsalis pedis pulses, often using palpation with our hand or a Doppler to assess. We also measure the cap refill on the toenails, which is the time it takes for the color to return to the nail bed after blanching, and normal is less than 3 seconds. Lastly, we then check for any foot deformities by examining for any bunions, hammer toes, or Charcot foot. In this section, we also assess if clients are wearing properly fitting shoes, which can prevent abrasions, calluses, and pressure injuries. This section also allows me to assess if a client does require new shoes or orthotics. Next slide. Based on the findings from that screening, clients are then categorized into risk levels. As you can see, the categories go from very low risk, which is low risk of amputations, to urgent risk, which is high risk of amputations. So for example, if a client comes in with a normal exam, which consists of no loss of sensation, no vascular disease, no skin abnormalities, and no deformities, they would be classified as very low risk and we would follow the recommendations and actions as providing education, daily foot inspections, appropriate footwear, nail care, etc. For any exercise programs, it's vital to consider a referral to a physiotherapist or a kinesiologist who can help support diabetic patients with appropriate exercises. As a client begins to show any loss of sensation or vascular disease, they are then categorized according to their risk, and this then allows me to provide the appropriate intervention as guided by the INLOS. Screening should be performed according to the recommended screening frequency. For example, low risk is every 12 months for a foot exam, and high risk is every 1 to 3 months. And urgent risk usually requires urgent management, such as referral to vascular surgery. Regular use of this screening tool can reduce the incidence of diabetic foot complications by enabling early detection and timely intervention. Slide. So what does an abnormal diabetic foot assessment look like? If there's any loss of sensation with monofilament testing, that increases the risk of injuries and infections since clients cannot feel if they were to injure their foot. If the client has any reduced blood flow, such as PAD, with little to no pulse, it may impair healing and increase the risk of infections. If any signs of vascular disease are suspected, we can send for ultrasounds to further assess. Any skin concerns such as cuts, blisters, sores, or infections can lead to poor healing in diabetic patients and causing severe ulcers, infections, and osteomyelitis. Any abnormal footwear that's either too tight, not wide enough, not enough orthotic support can also lead to abrasions and pressure injuries. Any structural abnormalities such as a bunion, hammer toe, or Charcot foot can also lead to pressure points or ulcers. Hammer toes are a condition where one or more of the toes become bent at the middle joint, causing them to resemble a hammer. If hammer toes are suspected, we can refer to our physiotherapy clinic for appropriate wide shoes, orthotics, and hammer toe splints, along with education on foot stretching exercises. Charcot foot is often associated with neuropathy, especially in people with diabetes, as previously discussed by Dr. Coates. Charcot foot presentations usually require urgent management and referral to vascular surgery. Prevention is from regular foot exams by doing INLOS screenings, blood sugar control, foot protection, and early infection intervention. Slide. Now that we've reviewed how we screen diabetic patients, I will now talk about how we assess wounds in the clinic. So this tool can be applied to patients with or without diabetes. So as Dr. Coates previously mentioned, we do assess wounds using NIRS and Stonies as a way to evaluate whether infection is present in a wound, along with using this tool as a guide. The PWAT tool is an instrument used to evaluate and monitor wound healing through photographic images, along with using photos uploaded to the EMR after each client visit with their consent. This tool allows us to assess various wound characteristics, as you can see, looking at the size, depth, necrotic tissue, etc. Each of these attributes is then scored on a scale, contributing to the total score that reflects the wound status. The higher the score, the more severe the wound. Our goal is to treat the wound accordingly, whether it's prescribing oral or IV antibiotics if infection is present, providing wound care in the office, and then referral to CCAC to continue according to best practices. We continue follow-up on a weekly or bi-weekly basis, whatever is appropriate for the client, and the goal is to have the majority of the PWAT scores to be reduced by over 50% in order for clients to be considered appropriate for a discharge back to their primary care doctor, or that they're actually doing well with the treatment provided. If the wound scores and clinical presentation of a client can deteriorate or worsen, this is when we consider further management, such as sending for x-rays, bone scans, MRIs to check for osteomyelitis, or referral to vascular surgery if needed. Next slide. So as mentioned previously, monofilament testing is an important tool used to assess for sensation in the feet of people with diabetes as they're at risk for diabetic neuropathy. When using a monofilament, you hold the device perpendicular to the skin and press gently until it slightly bends, as demonstrated in the picture. So you want to apply the monofilament to the 10 areas as shown on the INLOS diabetic screen, where you assess it for at least 1 to 2 seconds at each spot. If the client's unable to feel it, that area is considered lacking sensation, which could indicate nerve damage. This tool is quick and non-invasive, so it's great to use. Next slide. The handheld Doppler is a device we use when dorsalis pedis or posterior tibial pulses are not palpable on exam. An absent or diminished pulse on physical exam usually warrants further investigations for PAD, such as arterial ultrasound, to assess ABIs. A wound measuring tool helps keep track of the length and width of the wound in our charting, and the PWAT tool to assess if a wound is healing over time. Slide. By using a cotton tip applicator, the healthcare providers or myself can explore the wound to assess its depth. The applicator can help gauge whether the wound is superficial, moderate, or deep, especially in cases where the wound's depth is not immediately visible. Slide. So this is a brochure from Wounds Canada that we use to assess the appropriate management for patients. As the brochure shows, the less severe presentations such as numbness, pain, and tingling in the feet can consist of interventions such as encouraging blood glucose monitoring, referring for foot care with our nurse, or referral for professional footwear. We also have an affiliated physiotherapy clinic where we can refer clients when appropriate for orthopedic shoes, orthotics, and diabetic socks. We can also refer clients to diabetes wellness or a dietitian for education regarding their diabetes as well. So various presentations require various management techniques, but our ultimate goal is to provide patients with education and care based on evidence-based practices. Wounds Canada also has excellent resources if anyone is ever interested in viewing. Okay. So for any client that is assessed in our LLP clinic, whether they're very low risk or urgent risk, the importance of education is vital. Many clients, unfortunately, do not understand the detrimental effects of diabetes or vascular disease on their foot health until it's too late. It's extremely important to educate clients on every visit to check their feet every single day. So you want them to check for ulcers, sores, cuts, redness, bruises, calluses. It's also important to educate your patients on what an infection looks like fevers, chills, worsening pain, redness, etc. You want to ask them to use a mirror to see the bottom of their feet, especially if there's neuropathy present, because they're unable to see if there's any cuts or bruises there. You want to remind them to wash them with soap and water, cut nails straight across to avoid ingrown toenails, moisturize but not between the toes, and really encourage them to wear well-fitting footwear indoors and outdoors, and try to have them avoid walking barefoot, especially in the summertime. Next slide. So this is another pamphlet from Wounds Canada provided to clients during their visit for self-management, where they're required to assess their feet daily with a worksheet. So on the right side, you can see it's a worksheet from Sunday through Saturday where they can monitor their feet every day, mark R if they notice any redness, C for callus, etc. The information on the left is just reiterating how clients can cut their toenails appropriately at home. However, I do usually encourage a referral to a qualified foot care nurse as well to provide them more support with their skin and nail care for their feet. At the end of every visit, I usually send a note back to the referring doctor or either the primary care doctor and the referring provider with our assessment findings, including the INLO scores, wound assessments, management plans for any infections, for ulcers if applicable. For example, if we did place them on antibiotics or any referral to wound care. If they've been referred for any new supplies, such as shoes or orthotics, and if there's any recommendations for holistic care, including referral to endocrinology for their diabetes, physiotherapy, dietitians, or pain management if needed. We continue to send updates to the primary care doctor throughout the treatment so they're aware of the plan for their patients. So as clinicians, it's vital to continually educate patients throughout each encounter on the importance of lower limb care and daily practices so they can implement it in their lives to reduce risk of infection and amputations. Next slide. So I'll talk a little bit about the transient population base that Christen touched on earlier. So in addition to seeing clients in the office, we had an opportunity to work closely with marginalized populations at a shelter health site, H4. Providing wound care to these populations presented several significant challenges, which included both medical and social factors. So some examples included lack of stable housing, which led to lack of clean environments and exposure to the elements, which contributed to delayed wound healing. There was also limited access to medical care, so many wounds were not treated in a timely manner. Many of these individuals had unknown underlying health issues such as diabetes or vascular disease, which impaired wound healing. Mental health issues such as depression, trauma, or substance use, and lack of resources such as clean dressings all impaired wound healing. Lastly, many of these individuals have temporary shelters and move around frequently, making it difficult for healthcare providers to follow up on wound healing or addressing complications due to lack of continuity in care. There's a lot of stigma and mistrust from these individuals, unfortunately, towards medical providers due to history of discrimination or judgment, leading to reluctancy in seeking care. So as summary, there are many social determinants of health that affect these clients, including food insecurity, lack of transportation, unstable employment or no place of living, no transportation, and low socioeconomic status, which all contribute to delayed wound healing and complications. Many of their injuries can be difficult to manage due to limited access to timely care and resources. So fortunately enough, we were able to provide care by building trust and approaching these clients in an open and non-judgmental way to the best of our abilities. When clients would approach our clinic, we would collect the client's history and concerns and provide care that was most realistic for the client. Many of these clients did not have an OHIP health card, so we were able to dispense an oral or topical antibiotic if any signs of infection were present and provide Tylenol or ibuprofen if needed and appropriate. We would still have the ability to swab wounds for culture and sensitivity if needed. However, sometimes follow-up was difficult due to lack of phone and etc. So we would always try to follow up through the patient's caseworker if they did have one. We had all types of wounds, including physical trauma like cuts, bruises, burns, and more severe injuries from altercations, accidents, or falls. We also did have a handful of diabetic ulcers, venous ulcers, IV drug abscesses, or just simple abrasions. So we would provide wound care to these clients in the clinic and then provide them with more clean supplies and education on how to continue dressing changes once they left our clinic. Some of our dressings included, but were not limited to, Inidine, Silver Cell, Meta Honey, Bactograss, gauze, 4x4s, and tape. We work closely with clients' housing workers to provide transportation to imaging departments if needed, referral to our affiliated physiotherapy clinic, and referral to foot care if applicable. There were some cases where oral antibiotics, whether it was dispensed by us or prescribed if they did have a health card, that were not first line and the client did require IV antibiotics or more expensive treatment. If that was the case, we were able to set up transportation to the hospital and communicate ahead of time with the emergency room if needed for an emergent referral. One of the most difficult barriers to providing care was that the clients did not follow up on a weekly basis, or they simply did not want to go to the hospital for further management if that was required. Although we would try our best to provide education on the risk of not following through with recommended treatment plans, we would use a harm reduction approach on whatever was realistic for the client. Over time, we built rapport with many of the clients there, and they would follow up with us on a weekly basis, usually between 1 to 4 p.m. on Thursdays, for regular wound care and picking up appropriate supplies, which we still do, but via virtual assessments. We did have many success stories which displayed effectiveness of our efforts. Overall, collaboration with shelters and community organizations can also provide easier access to care, hygiene products, and social services. Developing trauma-informed and culturally sensitive healthcare practices is essential to building trust and improving care to this transient population base. Thank you for listening, and now I'll hand it back over to Dr. Coates to kick off our first clinical case discussion.
Hello. I will now present 2 cases assessed and treated by the Windsor Lower Limb Wound Prevention and Treatment Clinic. So case number 1 is a diabetic foot ulcer case. I guess I gave the answer away. Next slide. So this case 1, Mr. P. This 52-year-old male presented to his primary care practitioner's urgent care clinic on the evening of October 26, 2024, with the complaint of a blister on his left 5th toe. The onset of the blister was many months prior. Then after a long walk in Ojibwe Park, the blister burst and there was purulent discharge. The patient went to a walk-in clinic the day prior, on October 25th, where, quote, the doctor refused to prescribe or do anything, end quote. Past medical history, this patient had diabetes type 2 diagnosed in 2000, complicated by diabetic retinopathy, diabetic peripheral neuropathy, high blood pressure, high cholesterol, obesity with bariatric surgery, obstructive sleep apnea, major depressive disorder, and he was an occasional smoker. Medications included gabapentin, Zigduo, Januvia, Coversil, Zoloft, Wellbutrin, and Percocet. And on examination, a small ulcer was noted between the 4th and 5th toes. The 5th toe appeared macerated and edematous. There was erythema, heat, and edema present and spreading 3 centimeters up the dorsum of the foot. Pulses, cap refill, sensation were not documented in the urgent care physician's note. Assessment and plan, he was diagnosed with infected diabetic foot ulcers on the 4th and 5th toes with a cellulitis, query osteomyelitis. A CNS swab was taken. He was started on oral clavulin and topical fusidin. X-ray foot and labs were ordered, and the patient was advised to follow up with his primary care practitioner in 1 week. Next slide. So here's our first case study question. And you can all select this and we'll be able to see what you think the answer should be. So which of these assessments and/or interventions are not recommended? A, applying a protective dressing to the wound. B, advising exercise to improve circulation to the foot. C, inspecting the patient's footwear for appropriate fit, any defect in the shoe that could cause trauma. D, asking the patient about the presence of pain, its location, onset, duration, quality, worsening, relieving factors, and severity. E, none of the above. So you can all vote on that, and in a few seconds, we'll see what you guys thought. So the answer is B. Advising exercise to improve circulation in the foot is not recommended. The patient should be advised to immediately offload the affected foot, as continued weight bearing and pressure will cause further damage and prevent wound healing. And I'm sorry, did we have a breakdown of what people had selected? Yeah, okay. So next slide, question 2. What parts of the physical examination were not assessed nor documented adequately by the urgent care physician? A, peripheral vascular exam, i.e. pedal pulses, capillary refill. B, sensation, perhaps with use of a monofilament. C, description of the wound, size, length, width, depth, appearance of the wound bed, presence of exudate, debris, and odor. And D, vital signs. E, all of the above. So we'll wait for your response. The answer is E, all of the above. So these are all useful information that you should be documenting when assessing a diabetic foot ulcer. Next slide. So question 3, what interdisciplinary referrals might the urgent care physician have made for this patient? A, referral to a lower limb preservation site clinic. B, referral to a vascular surgeon. C, referral to Ontario Health at Home Wound Care Clinic. Advise the patient to follow up with their primary care practitioner, and the scoring you could do. And the answer is E, all of the above. Next slide. Are we going to the next slide? So going on with how this patient progressed, investigations, the CNS swab group, strep group B and Staph aureus. His CBC was normal. His inflammatory markers were high. A1C was a bit too high. Random glucose was high. The patient was assessed by his PCP on October 30th, at which point his vitals were normal, although his heart rate was a bit tachycardic. Left foot was hot to touch, edematous with erythema present. The area affected had progressed up the dorsum of the foot over the lateral malleolus and anterior aspect of the ankle. I wish we had a photograph of this, but the foot was quite swollen, hot, angrily red, and it almost, in the differential, you might worry about a Charcot foot. Pedal pulses were excellent. Cap refill was normal. Fine touch via monofilament testing was absent up to the midfoot. There was excoriated skin opposite callus between the 4th and 5th toes, and an ulcer to the lateral aspect of the 5th toe. The assessment plan was of an infected diabetic foot ulcer, left 5th toe with cellulitis, query osteomyelitis. It was advised the patient to go to the emergency department to initiate IV antibiotics, an urgent referral to Ontario Health at Home Wound Care, and offloading. The patient worked at U-Haul and did lots of walking, lifting, so he needed to be placed off work as further weight bearing will impair healing. To note, patients may need help from Ontario Health at Home regarding personal support workers, physio, and occupational therapy to assist with offloading and manage ADLs while offloading, especially in elderly patients. So we need to remember to treat the whole person, not just the hole in the person, and think of ways we can assist them in keeping pressure off this wound. Next slide. Patient went to emerge on October 30th, where he was started on IV ceftriaxone. The ER physician thought there was no indication of osteomyelitis and didn't do an X-ray. However, the patient did go the next day for his X-ray, previously ordered by the urgent care MD, and it showed distraction of the middle phalanx with some bone fragmentation associated with an underlying bone expansion and pathological intra-articular fracture extending at the base of the middle phalanx at the PIP joint. Resorption of bone at the lateral aspect is seen, marked diffuse soft tissue swelling, bone abnormality, and destruction involving the terminal phalanx as well. It was unable to visualize the distal interphalangeal joint consistent with joint distraction. Findings were in keeping with septic arthritis and osteomyelitis. Surgical opinion was recommended. The proximal phalanx appeared intact and the 5th metatarsophalangeal joint was intact. Next slide. So this is his X-rays, and you can see the 5th toe on the left is disintegrating. And I like this side view showing the claw toes and hammer toe deformities. Next slide. This is a close-up of his distal phalanx of the 5th toe, showing the significant swelling and bone disintegration. Next slide. The patient followed up with his primary care practitioner on November 1st, at which point the cellulitis had improved by 1/3. The IV ceftriaxone was extended for another 4 weeks due to the osteomyelitis. Best practice wound care and offloading by the wound care clinic was requested. He was referred to a vascular surgeon and to the Windsor Lower Limb Wound Prevention and Treatment Clinic. Next slide. At the vascular surgeon consult November 7th, the ulcer was debrided and revealed healthy pink skin underneath. IV antibiotics were continued and he was to follow up in 4 to 6 weeks. The lower limb program saw him on November 18th, at which point the cellulitis and ulcer were greatly improved and there was no redness, no pain, no warmth to touch, pulses were excellent. And next slide shows his photograph of his foot at this point. So some mild redness now just extending above the toe, and a lot of peeling skin where the foot had been swollen like a balloon, and this macerated looking wound on the fifth toe. Also between the fourth and fifth toe, there's some tissue damage. So next slide. This is his inlows. So it's documented the loss of protective sensation, foot deformities, the presence of pulses being present. And the next slide is the risk stratification, which, because he has a diabetic foot wound, he's automatically placed in the urgent risk zone. And there's the recommendations for follow-up and management on the inlows. Next slide. This is his PWAT. The PWAT score on his first visit at the lower limb program was 11. And next slide. Management by the lower limb wound prevention and treatment clinic was wound care provided, foot care education provided at all visits. A PICC line was arranged, an offloading boot for a corridor consult with the vascular surgeon. He was referred for foot orthotics, orthopedic shoes, hammer toe splints, and diabetic socks. And that's via our by our physiotherapy clinic we work with. Referral to smoking cessation. Foot care nurse was to be seen later after this wound was healed. And we do have a foot care nurse accessible through the Windsor Team Care Center. Next slide. On November 26th, the toe was healing well. Amputation seemed highly unlikely. He was off work, though, through January 1st. December 12th, it was almost completely healed. He saw the vascular surgeon on December 12th, who felt the osteomyelitis was resolved. So next slide. And he discharged the patient on December 12th. December 16th, his PWAT was 4, and he was referred to the foot care nurse. He was advised to follow up every 1 to 3 months for inlows, high screening, high risk. Here's a photograph on the next slide. On December 16th, a PWAT of 4. On January 13th, the wound had opened slightly, so his PWAT went up to 5. Wound care was provided, and he was referred back to Ontario Health at Home Wound Care Clinic. He was provided with a diabetic offloading boot, advised to wear daily to allow the wound to heal. Next slide. This is the PWAT of 5, so it looked a little bit worse on January 13th. On January 26th, he was assessed by the primary care physician again, at which point he noted the fifth toe wound open again, very shallow superficial ulcer. He was followed by the lower limb wound prevention clinic and by Ontario Health at Home Wound Care. PCP suggested referral to orthopedic surgeon regarding his toe deformities. Are there any possibilities of ideas for offloading and possible surgical interventions for the clawfoot hammer toes to prevent future diabetic foot ulcers? Per the International Working Group of the Diabetic Foot 2023 guidelines, orthopedic procedures such as flexor tenotomy or Achilles tendon lengthening should be considered to prevent development recurrence of foot ulcers. And it should be noted that these patients are at high risk for recurrence of diabetic foot ulcers at the original site and at other locations on the foot. Patients are not one and done. This is a chronic condition that requires lifelong vigilance and follow-up by both the patient and his clinicians. Next slide. Over the next 5 weeks, the ulcer improved greatly to a PWAT of 3. So here's a PWAT 4, and then the next slide, PWAT 3. And he continues to follow Q1 to 3 months with the lower limb wound prevention clinic as he is high risk. Case 2 is a venous ulcer case. So this is Mr. J. This 82-year-old male presented to the emergency department on September 25th, 2024, regarding a large blister on the left lower leg. The blister was lanced and drained during the ER visit. Patient reported pain. The area was warm to touch and erythema was present. Moderate serosanguinous drainage noted. Patient was referred to Ontario Health at Home Wound Care. Inidine and gauze dressing applied. Patient was also referred to the lower limb wound prevention and treatment clinic. Past medical history included chronic lymphocytic leukemia, severe osteoarthritis of the right knee, gout, pedal edema, and hypoandrogenism. Medications included venetoclax, which is a biologic for his leukemia, allopurinol, Zopiclone, Lasix, spironolactone, Tylenol, and testosterone injections. Allergies included tetanus and penicillin in childhood, but apparently had taken it as an adult with no reaction. Next slide. At his initial visit with the lower limb clinic on September 30th, he was noted to have left lower leg presenting with mild pitting edema, erythema, tenderness, wound bed 7 by 7 centimeters in size. The leg was warm to touch. Pulses were present bilaterally. PWAT score was 9. And he was diagnosed with a venous wound infection with cellulitis. CNS swab was obtained. Wound care was done, including Bactigras, non-adherent foam applied, wrapped in gauze, and patient encouraged to frequently elevate legs above heart level when resting. The wound culture showed Staph aureus and was treated with cloxacillin orally per the sensitivities. Next slide. So there's a picture of his wound, PWAT of 9. Here is his PWAT score. And on October 10th, he followed up. The wound was improved significantly. He was seeing the wound care clinic through Ontario Health at Home on Monday, Wednesday, Friday. The wound was now 4 by 4 centimeters. There was scant discharge, and their surrounding skin was intact. The edema had decreased. PWAT score was 6. It was thought that he was improving. The oral cloxacillin was extended for 3 more days. Next slide. Here's how it looked on October 10th. So you can see it's much better, almost half the size of the original visit. Next slide. On October 17th, the left lower leg wound continued to improve. It was now 2.3 centimeters in size. Minimal or scant serosanguinous discharge. PWAT score was 4. He was referred to the Windsor Team Care Center foot care nurse. Next slide. And here's the picture of the PWAT of 4 on October 17th. Next slide. October 21st, the wound care nurse was concerned regarding his left lower leg looking red and swollen. There was no new wound, but there was tenderness to the medial aspect of the left foot. The lower limb clinic found that he had 2+ pitting edema on this occasion, tenderness present, hot to touch. Pedal pulses were difficult to palpate due to the edema. They considered a cellulitis versus a deep vein thrombosis. He was sent to emergency to rule out DVT and initiate IV antibiotics if indicated. It's noted he had a past history of a DVT 10 years earlier during his chemotherapy. Next slide. So lower limb clinic follow-up on October 25th. This was a phone consult. He had reported he had been started on IV Rocephin on the 22nd. Venous Doppler was negative for DVT. He was seen in person on October 30th, and he was much better on the current antibiotics. Redness, pain, edema improved. Venous ulcer improved. The wound was now 2 by 1 centimeter, minimal to no drainage, with a PWAT score of 2. Next slide. There's a picture of his wound on October 30th, so almost completely healed. Next slide. On November 7th, he was reassessed. He had completed his IV antibiotics. His PWAT was down to 1. This wound was basically healed, and the cellulitis was resolved. He was referred to Cunard Physio for bilateral lower extremity compression stockings and to treat the venous insufficiency and thus avoid venous ulcers going forward. He was encouraged to elevate his legs when resting. He saw the vascular surgeon who recommended compression stockings and ordered arterial Doppler ultrasound. Next slide. There's his PWAT score of 1. I think there's some inidine stain there, but if one looks closely, I think there's just a tiny little opening. So it's not as large as this yellow area. Next slide. December 9th, his PWAT score was 0. Venous ulcer and cellulitis resolved. He had chronic venous insufficiency. It was recommended he wears compression stockings, exercise 30 minutes per day, especially walking, and continue elevating his lower extremities when resting. He was to follow up in 3 months. Next slide is case question. What additional workup would be appropriate? A, assess gait and ankle mobility for abnormalities that may impair calf muscle pump function. B, venous insufficiency Doppler ultrasound vein mapping. C, investigate other coexisting medical conditions that can contribute to pedal edema. Example, congestive heart failure, rheumatoid arthritis, lymphedema. D, ankle brachial pressure index, arterial duplex ultrasound. Or E, all of the above. So we'll let you vote. And the answer is E, all of the above. Next slide. Question 5. Which of the following interventions is not recommended for the treatment of venous leg ulcers? Muscle pump activator. B, compression therapy wrapped stockings. C, offloading and rest until the venous ulcer heals. D, foot elevation above heart level daily. E, best practice wound care, which may include advanced treatments such as negative pressure wound therapy. F, venous ablation therapy. So which of these interventions is not recommended for the treatment of venous leg ulcers? So you can vote on that. So the answer is C, offloading and rest until the venous ulcer heals is not recommended. In fact, calf muscle contraction exercises, especially a daily walking regimen, are recommended, as physiotherapy may be needed to assist if there are gait and ankle mobility problems. The muscle pump activator, this is a device that stimulates the peroneal nerve, thus enhancing calf muscle pump function, which improves venous, arterial, and microcirculation. So that concludes my part of this evening's webinar. Now Harrison will introduce our next distinguished speaker.
Yeah, thank you so much, Dr. Coates, for walking us through those cases and highlighting the role of primary care in early identification and intervention. Now happy to introduce our next speaker, Dr. Maher Sabalbal. Dr. Sabalbal is a vascular and endovascular surgeon with Windsor Vascular Care and Windsor Regional Hospital. He brings a wealth of expertise in the diagnosis and management of peripheral vascular disease. Tonight, he'll be presenting on a complex peripheral artery disease case and sharing insights from the surgical and vascular lens.
Thanks, Harrison, and thanks everybody for the invite and for tuning in on a cold, beautiful Tuesday evening. There's nowhere else we'd rather be than right here, right now. So let's get this done. Next slide, please. So we all kind of know this. I have never seen this movie, so I don't know if you guys have ever seen it. It has nothing to do with what I'm going to talk about, except that it has a cool topic that fits in with the usual risk factors for cardiovascular disease. I always stress the importance of, number one, identifying them, but more importantly is evaluating how well controlled these are. It's very easy to just kind of put a check mark beside smoking, diabetes, hypertension, dyslipidemia, but not delving a bit more in detail to find out, okay, well, how is your A1C controlled? Do you have an endocrinologist? Do you visit a diabetic foot clinic? What are your sugars day to day? What kind of numbers do you get? Is somebody following that for you? These are all important questions for diabetic patients. And you'd be surprised how many patients answer negatively to all these questions. Hypertension, same thing. Okay, you have high blood pressure. Well, what is it at? Do you measure it regularly? And then, no, not at a doctor's office, at home. Do you have a blood pressure machine? What kind of numbers do you get? And then same with the dyslipidemia. So it's important to delve in detail to tease out the risk factors here, because these are the melting pot where PVD is brewed. Next slide, please. So these are the not so usual risk factors for cardiovascular disease. Now, obesity is, of course, a risk factor for a lot of things. PVD is not a surprise that it's on there. Inflammation, state of chronic inflammatory state from various things, elevate CRP and fibrinogen and put patients in a prothrombotic state. Flu, COVID-19, eating processed food, simple examples where these patients are in a constant inflammatory state are known biomarkers for PAD severity. Homocysteine is another risk factor that's kind of being evaluated in a bit more detail. The strength of the association here is moderate in comparison to smoking and hypertension and diabetes, which have very strongly associated to this PAD severity. And socioeconomic status, as was kind of discussed by our previous speakers, really kind of delves into the importance of, evaluating the patient's lifestyle, what kind of livelihood and how their livelihood impacts on their overall health state. Next slide, please. So, question, what is the impact of screening asymptomatic patients for PAD on limb loss? So I'll have you think about this for a second. So A, no impact. B, reduces amputation risk by 5% over 5 years, increases amputation risk due to unnecessary intervention, increases risk of MACE or major adverse cardiac events due to unnecessary intervention, or E, reduces amputation risk by 10% over 5 years. Okay, next slide. Let's see the answer here. No impact. So many guidelines published from the Society for Vascular Surgery, Canadian Society for Vascular Surgery, Canadian Cardiovascular Society all recommend against routine screening for PAD patients. Now, there are some exceptions to this, not kind of detailed in paper, but if you have a patient who, for example, has had a CABG a couple of years ago, is an elderly and is a diabetic, and you just want to evaluate to see, do they have carotid artery stenosis? Because that could be important for future cardiovascular events, or do they have symptoms within their lower extremities that may suggest PVD, then maybe you're okay to send them for a screening ultrasound. But as a general rule, it is not recommended for patients to have a routine one-time screening ultrasound to rule out PAD. It is not shown to reduce amputation risk, and it's not shown to be cost-effective, which is the two most important things when we consider screening populations. Okay, next slide, please. All right, so let's get down to the nuts and bolts of things here. We've heard about claudication. We've heard about critical limb-threatening ischemia. It's very important to separate the two. These are two completely different patients with completely different risk profiles moving forward. the most important thing that we consider with claudication or with critical limb ischemia is what is their annual limb loss rate? What is their survival in the next 5 years? So you can see on the graph here, the dotted line indicates critical limb ischemia. The black kind of square circle indicates claudication, and the white square circle indicates control patients. So if you follow these patients for just a year, you can see how precipitously the mortality of patients with critical limb ischemia drops. And if you look at 5 years and look at 10 years, there's a huge stark difference in mortality. Now, when we talk about limb loss, it's different story. For claudicants, the risk of limb loss is very, very, very low at 1 year and at 5 years. For critical limb ischemia, that's not the case. And the two diagnostic features for critical limb ischemia is rest pain and tissue loss. So these are two simple things to remember as red flags to raise your attention a little bit to say, okay, well, does this patient need urgent assessment by vascular surgery? Do they have rest pain or do they have tissue loss? If they have any of these two things, then we should send them for an urgent consultation or urgent ultrasound to document how significant this might be. Next slide, please. So when we look at critical limb-threatening ischemia, what goes through our heads as vascular surgeons and as primary care providers, because you guys are the gatekeepers of our healthcare system, so to speak. So we rely heavily on your clinical judgment and on your expertise in helping us manage these patients. So the risk of if you look at 5-year outcomes and you divide their risk between limb morbidity and cardiovascular morbidity, with claudicants, we are more concerned with cardiovascular morbidity. They are more likely to suffer an MI or a stroke than they are to lose their limb. So it's very important. The risk of crossing over into a critically ischemic limb is only 1 to 3% over 5 years, whereas the risk of MI or stroke is 20%. The risk of mortality, probably because of their MI or stroke, is 10 to 15%, which is why we harp on the importance of optimizing medical therapy as a mainstay of treatment for patients with claudications, and rarely do they ever need any surgical intervention. Next slide, please. So when we talk about medical management, what are the things that we are talking about here? Most of these things are a review, but let's just talk about some things in detail. Smoking cessation is without question the hardest yet the most important thing that we can try and eliminate as a risk profile. We talked about elevated biomarkers of inflammation as a risk factor for PAD. I mean, smoking is well described across the board in terms of the harmful toxigenic effects it has on the vascular endothelium. So a lot of surgeons are pretty stern and will say, I will not operate on you until you stop smoking. I think there's a nice, gentle way to deliver this message to our patients, because often our patients become very defensive if you provoke them, if you accuse them, if you talk to them in a demeaning way about their smoking habits. So it's more effective to approach the subject in a more gentle demeanor, giving them some target, asking them how much they smoke. Well, what if you cut it in half? What if you have a cigarette or two with your morning coffee and with your evening coffee, and in between maybe try and eliminate. Start somewhere with them and then start working towards eventually stopping. And if they can't fully stop, you know what? That's fine. We'll take it, because if they smoke 1 to 2 packs a day and you're able to get them down to smoking 5 or 4 cigarettes a day, we'll call that a win. And we'll work on the next 4 to 5 cigarettes over the next couple of years. But just getting them to at least cut back is half the battle. Now, in terms of medical therapy, aspirin has to be on the recipe for PVD patients. There is absolutely no benefit for Plavix or clopidogrel over aspirin in patients with PAD. In fact, I hate seeing it because, number one, it is not cost effective. Plavix is more effective than aspirin. Number two, several trials, including the MATCH trial from decades ago, have shown no significant difference in reducing risk of cardiac or cerebrovascular events when comparing aspirin to Plavix. And number two, Plavix stays in the body for up to a week. So if they have a major bleeding episode, if they're in a trauma, a lot of their patients are elderly, then maybe they have a fall, maybe they get a GI bleed, you're stuck with Plavix for a week. Whereas aspirin's half-life is 24 hours. So why give Plavix over aspirin? There's no benefit for it that's documented. Number two, statin. Every PAD patient has to be on a statin if they can tolerate it. And the recommended dose is the maximum dose that a patient can tolerate, regardless of their LDL levels. We are not just targeting LDL levels here. In fact, there are no published guidelines for LDL targets in patients with peripheral vascular disease. Of course, there are well-known targets for patients with cardiac disease, but not for patients with established peripheral vascular disease. So we're not just targeting LDL levels. In fact, statins have multiple pleiotropic effects on the vascular endothelium, which include improving myocardial perfusion in ischemic segments, improved vasodilatory response to acetylcholine, increasing the bioavailability of nitric oxide and antioxidants, improving their pain-free walking distance, decreasing their CRP and inflammatory states, modulating their immune systems. I mean, there are just a plethora of other important advantages that statins have that are often not thought about or considered when prescribed to patients. Now, if they obviously have an adverse reaction, they can't tolerate a statin, you don't just stop it. You switch classes first. You lower the dose first. And then if they keep having side effects to at least 2 or 3 different statins, then I think it's okay to switch over to some other lipid-lowering drug. Tight glycemic control for diabetic patients. There are trials that have been published to see, okay, how tight is tight? What hemoglobin A1C levels should we aim for in PVD patients? One of the trials showed that if you try and aggressively treat the A1C to below 6%, you're actually causing harm to the patient. And so the nice window for PVD patients to target is 6 to 7% for A1C levels for diabetic patients. So that should be our target for our diabetic patients in general. And then, of course, tight blood pressure control is important. For patients with cardiovascular disease, the first antihypertensive that you should think about is an ACE inhibitor or an ARB. ACE inhibitors and ARBs are also have very important advantages on the vascular endothelium. They stabilize what's called the shoulder region of plaques within the vessels. Often the patients have some degree of chronic kidney dysfunction, so the ACE inhibitor actually helps modulate that. Same with patients with heart failure. The ACE inhibitors have beneficial effects in that regard as well. Now, pharmacotherapy aside, probably the most important thing that these patients can do is walk. The CLEVER trial is a very important study that was published a couple of years ago that compared supervised exercise therapy with primary stenting, so an intervention for disabling claudication, so not CLTI patients, but patients with disabling claudication due to aortoiliac disease, so plaque within the aorta or the iliac arteries. And at 6 months, it showed that the peak walking time was greatest in the patients who received supervised exercise, not in the patients who received a stent. So that goes to show how important and effective a regimented walking program is. And the way if I could put it on a prescription pad and give it to my patients, it's even better. And I tell them very specifically, you have to walk every day. Most of you are retired, so you got lots of free time on your hand. There's no excuse. Get your shoes on, go outside. It's cold out, go to Devonshire Mall. Got nice long strip for you to go walk. You got Tim Hortons, you got nice shops. There's lots of areas where you can sit down and rest. If you fall or something bad happens to you, there's people around that can pick you up. There's no excuse. You got to walk every single day, because walking or exercise not only improves your walking distance, not only does it improve your collateral flow when you have occluded arteries, but it also does all the above. It helps manage your diabetes. It helps manage your hypertension. It helps reduce your inflammation. So there's no substitute for walking. So we give these all these kind of non-invasive therapies a shot, at least 6 to 12 months. And almost always patients come back and they can't believe the difference. Just today, I saw a patient who had an occluded SFA, superficial femoral artery. His ABI went from 0.7 to 0.9, almost normal, just with walking. He's like, I can walk 10 kilometers now, he was telling me. Before, he'd get claudication after 2 blocks, but after 12 months of just saying, walk, 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 walk. He's all about walking now. Now he's making avocado smoothies and taking all these supplements, and he's just biking for charity. It's like, man, this is amazing, right? So they just feel better when they do that. So the importance of walking and exercise cannot be underscored for our patients. Next slide, please. Okay, so this is a review because it was already in the slide deck. See if you guys are falling asleep on me yet. I know it's dinner time, but let's see this. So what is the risk of annual limb loss in patients with claudication? I didn't see the answers from the previous slide. Is there a way that the answers can actually pop up from our... Okay, let's see the answer. Next slide, please. Exactly, 1%. So again, I don't see who chose what, but that's the correct answer. So if you chose that, nice, good job. Next slide, please. Next slide, please. Okay, so this is in comparison to patients with critical limb-threatening ischemia, their risk of limb loss in a year is 20%. So huge difference, which is why there's such a stark difference in these two population groups. Okay, next slide. I know we're running short on time here, so I'll try to hurry up through some of this to get to our case. So critical limb-threatening ischemia, we've already talked about that it affects a minority of PAD patients. These are the typically associated ankle pressures, 40 to 50 in ankle pressure and less than 30 in toe pressure. You can't get a good ankle pressure in patients with diabetes because they have circumferential calcification of tibial arteries, so their arteries are non-compressible. So that instead as a surrogate of ankle pressure, we get what's called a toe pressure to get a good assessment of their PVD. Next slide, please. So when we see patients with critical limb-threatening ischemia, this is what kind of goes through our veins and our arteries as providers when we're trying to figure out what to do here. So the next step, rest pain tissue loss. What do? Physical exam. So physical exam is like, it's almost lost. So if you have a pedal pulse in the foot, you can palpate a posterior tibial and or dorsalis pedis. They do not have PAD. End of story. They don't need a Doppler. They don't need an ultrasound. They don't need anything. You have a pulse on the foot, then everything from the foot to the heart is open. They might have atherosclerosis here and there, but there's obviously no significant hemodynamically significant stenosis anywhere because you have a pulse. So that ends that discussion. So then whatever they're presenting with is not vascular. It could be something else. There is minority of patients, especially diabetics, like we said, who have palpable pedal pulses, yet they have an ulcer. So how do you make sense of that? Well, as Dr. Coates explained to us, it's a neuropathic ulcer from their peripheral neuropathy and has nothing or very little to do with their perfusion. And these are often younger patients, in their 40s, maybe 50s, long-standing diabetics, maybe type 1 diabetics who come in and they have these disasters in their forefoot, and they have a palpable pulse, like a booming pulse in their foot. So there's nothing to do in terms of optimizing flow, but there's lots to do in terms of offloading them, getting them proper wound care, improving their neuropathy with proper orthotics and things like that. Next slide, please. So this is a very nice way of grading patients with critical limb-threatening ischemia. Previous grading scores included the Rutherfords and Fontaines, which are old and outdated. This is a practical way of enhancing patient outcomes. Developed by the Society for Vascular Surgery and published in 2019. It stratifies risk, guides precise interventions, fosters coordinated care, shifting management from reactive to proactive, and more importantly, reduces amputation rates for patients. So it aligns all the important components of the limb. Is there a wound? If there is, it's graded 0, 1, 2, or 3, depending on how extensive it is. I'm not going to go through each of the values here. There is a calculator that we can use. Ischemia, what is the ABI? What is a TBI if you can't get an ABI? And number 3, foot infection. Is there a foot infection or no? So if you have 3, 3, 3 in every single group, then the limb is non-salvageable. You're not going to save much by revascularizing it. They need a primary amputation. And then if it's somewhere in the middle, you should probably do some type of intervention to reduce their Wi-Fi score. Next slide, please. So these are the Wi-Fi scores that are equivalent to the annual amputation risk. So 1%, 2, 6% annual risk of limb loss. If they're stage 3, 8%. If they're stage 4, 25%. And if it's stage 5, the limb is non-salvageable. So I often calculate this when I see patients with wounds to see how urgent I need to to revascularize them if there is something to revascularize. Next slide, please. Speaking of surgery, there's nothing I enjoy doing more than doing bypass procedures on our patients. Yes, I love it more than doing clinic. I think any surgeon who likes clinic more than surgery should not do surgery, but anyways. So this is a patient with a long saphenous vein getting ready for a bypass from the groin towards the ankle. So this is the routine kind of bread and butter vascular procedure that we do. It's indicated for patients with critical limb-threatening ischemia. It is not indicated for patients with claudications. This is pretty black and white for us. There is a small gray zone that we can consider in patients of disabling claudication who have failed medical therapy and their livelihood relies on their ability to move, to walk, and they just can't do it anymore. They've really tried, and it's just not getting better. So in that group of patients, we can consider something minimally invasive to just help them along. So the Canadian Cardiovascular Society in 2022, their PAD guidelines, they can be considered in good surgical risk patients who have diminished quality of life as a result of their PVD and have failed a trial of non-operative therapy. Then you can go ahead and consider something minimally invasive. Next slide, please. So when we talk about surgery, we think about aortoiliac or infrainguinal segments. So the two different anatomy requires different procedures. Aortoiliac patients, so those who have plaque, stenoses in their aorta, you could be surprised that patients can have an occluded aorta, like literally occluded, and they're still walking. It's just amazing how the body is able to divert flow and promote these large collaterals. But patients with aortoiliac disease have significant symptoms often and require intervention. Next slide, please. Okay, so with that in mind, we can move to our case study. So 67-year-old male was referred to me through the emergency room for right lower extremity pain and a right D1 ulcer. Past medical history, all the stuff that we just talked about, plus some other stuff like COPD. And this is important. The anxiety, depression part is often not addressed, but a lot of patients with PVD have that because they've been suffering for so long with it, and nobody's kind of guided them in the right direction as a result. On top of this patient is a lifelong smoker, has previous C-spine fractures, sleep apnea, has on a whole slew of medications, and is only 67 years of age. Next slide, please. So he tells me, started in summer 2021. First thing he noticed is severe cramping in both his lower extremities, in his thighs and his calves after walking 100 feet. And this continued to deteriorate until August, where his symptoms acutely worsened after he developed cellulitis of the right forefoot. So he got an infection. So now you have infection portion and the ischemia portion of the Wi-Fi score. And then he developed a foot wound, so add the wound portion. So now he has severe rest pain in both his lower extremities, but more severe on the right. He cannot sleep. So even as I was examining him at the bedside, he was very fidgety. Like he couldn't get comfortable. He had his leg up for a few seconds and he'd bring it down. So he can't even elevate his leg for a minute to talk to me during our history. On exam, restless, fidgety, can't seem to get comfortable. His foot is hyperemic. There's dependent rubor. He's got a dry scab over the PIP joint. He's got an eschar that's quite large over the right heel. His foot is very tender to touch, very warm. Cap refill is well over 5 seconds. No palpable pulse on exam. Not even a femoral pulse was palpable. So what's the next step? Next slide, please. So sorry, this is question 9. So what would you recommend for this patient? ASA, statin, follow up, see you later. Get a vascular ultrasound, refer to vascular surgery, start an ACE or an ARB, or would you do all of the above? All of the above options almost a giveaway for a lot of questions I've noticed, and just during my years of taking exams. If you ever see all of the above, it's almost always correct. So the answer is all of the above. Next slide, please. Okay, next slide. All right, so he was referred to me, did a CTA as a starting point. So what we're looking at here is the abdominal aorta in the top page. In the top picture. This is the right kidney on the right, left kidney on the left. You can see his vertebral body. You can see the circle with this white dense thing on the back wall of it. So that's his aorta with this calcified coral reef plaque sitting within the infrarenal aorta just above the bifurcation. And then the bottom picture is the proximal common iliac arteries. So they should look nice and circular with lots of contrast going through, but you can see a very compromised lumen on the right. The left, not so much. But remember, his symptoms were more severe on the right, which is where he got his infection. Next slide, please. So surgical plan. So I saw him, started discussing the options. That's not his imaging, by the way. This is what his imaging should have looked like and didn't. So we talked about open surgery. Aortobifermal bypass would have been the open procedure where we take a graft from the aorta above the plaque and bring it down to the common femoral arteries, bypassing the occluded aorta and bypassing the stenotic common iliacs. Endovascular, strictly endovascular approach, where we go to the OR, we make little incision in the groin, and we basically stent everything. Or hybrid approach, where we kind of take him to the OR, open the groins, dissect the common femoral artery, and then clean out the plaque, and then and then send stents up into the common iliac and the aorta. So even though he was 67 years old, which is fairly young for vascular patients, we often see patients in their 70s and 80s. So patients in their 60s, we consider them to be young. We opted for the CRAB procedure. I wanted to do the minimally invasive thing with him. He was a bit of a medical wreck. He had a very large pannus, so aortobifermal and a groin dissection would have been a bit of a disaster in his case. So CRAB procedure is called a common or covered endovascular repair of the aortic bifurcation. We put in a large balloon expandable stent in the aorta to crush that plaque and force it open. And within that large stent, we put smaller stents like a double barrel within it going down into each leg. So these are called kissing stents. Next slide, please. So these are the intraoperative angio images. So the image that you see on the right is the almost occluded aorta that you can see. So these two large arteries that are coming off the sides like arms, these are not the renal arteries. These are massive lumbar arteries that have become hypertrophied due to years and years and years of chronic ischemia and have basically been supplying the leg. They've basically replaced the common iliacs as the inflow into the leg. But, when the 401 gets jammed up and you can't take the 401 anymore, you got to take the back roads, but the speed limit is at 100. It's like 50 or 60. So even though you get there, it's going to take a much longer time. So what we ended up doing is we realigned the common iliacs, as you can see on the picture on the other side. And I wanted to stay below those large lumbars because I don't want to cover them in case the stents went down. I didn't want him to go down harder than what he was before. So we put a big stent that landed in the aorta just below these large lumbars, and into that big stent, we stented into the right common iliac and the left common iliac artery, and that basically treated his aortoiliac insufficiency. Next slide, please. And this is a CT scan. Post-op, you can see now the aorta, the plaque is basically gone. It's crushed by this massive stent in the aorta. These are the kidneys. And then the top image are now what his common iliacs look like. where there's nice contrast going down both legs, and now he had palpable femoral pulses, which was a very good sign. And his ABIs were basically normalized, 0.92 on the right, 0.96 on the left. The great toe was partially amputated where we had the ulcer, and that went on to fully heal and granulate post-amputation, as did the heel. Very important not to touch these patients with any form of debridement or amputation until you're sure they're going to heal it. It takes a lot more perfusion to heal a wound that's been amputated than to maintain a wound. So whenever we do any form of amputation or debridement, we want an ankle pressure of at least 60 for them to heal it. And if they don't have that, then they don't get any form of debridement or amputation until we get that ankle pressure. In terms of medical therapy, I put them on aspirin and Xarelto 2.5 BID indefinitely. So thank you very much for your time and attention, and thanks for your patience. Much appreciated. That's the end of my portion. Thank you very much.
Thank you, Dr. Sabalbal, for your insight, presentation, and for walking us through that complex PAD case. Your expertise and perspective as a vascular surgeon really helps us understand the critical role of early referral and timely intervention. Noticing the time, we will look to wrap up. This slide shows a few Ontario-based resources and guides that are available to support your continued learning and practice. This, along with key materials, will be sent to all that attended. Next slide, please. Few quick instructions on how to receive your certificate. The certificate can be used to submit to your respective college or licensing body to qualify for up to 2 CME or CPD credits, depending on your profession and regulatory requirements. A link to the certificate request form is being sent in the chat right now. So please take a moment to click on it and fill it out. It's a very short form, but you must complete it and submit it in order to receive your certificate. If you have any questions or concerns, please reach out to Christen Abraham. Her email is there right after the presentation. Next slide. We've officially reached the Q&A portion of our session. However, noticing the time, I will end with our closing remarks, and those that have any questions can stay on and ask questions with our full team of presenters here and ready to respond. However, I just want to send a thank you all so much for joining us. We truly appreciate the time, attention, and thoughtful engagement throughout the evening. Just a reminder, this session was recorded and will be made accessible to you following the event. You'll receive the link along with your certificate of attendance within 2 business days. You'll also get a follow-up package that will include our post-session evaluation and surveys. For those with questions, please stay on. For everyone else, we hope you found this education meaningful, practical, and we look forward to continuing this important conversation on lower limb preservation. Have a good evening, everyone, and thank you again for all the incredible work you do. For those that have questions, thank you for staying on. Whether it's about clinical cases, the tools we discussed, or anything related to the lower limb preservation strategy, please feel free to drop them in the chat now and we can discuss.
So there was a question that was posed to us in the chat for the hosts and panelists that I'll just open up here. So they are wondering if there's somewhere local that they can send patients with foot wounds for specialty offloading footwear. Does anyone want to take that one?
I could. So if they are a marginalized population, such as on our referral form for the lower limb wound prevention and treatment clinic, the referral form has those postal codes, or if they've been to emerge a lot or have other economic disparities, they can be referred to the lower limb program, which has access to foot orthotics and orthopedic shoes via Kunar physiotherapy. And I guess if they do have coverage through Green Shield or other health benefits, you'd refer them to podiatry or chiropody to access specialized foot care and offloading footwear. Also, the wound care, Ontario Health at Home, can assist with more complicated offloading boots, and our lower limb clinic can assist with that as well.
If I can just add on to that, you know, part of limb preservation, one of the really important missing members of the team are the podiatrists. I trained in Calgary, and our limb preservation clinic in Calgary, we worked side by side with podiatry. They had full hospital privileges. They saw patients billed to the Alberta government, and in the United States, it's standard of care. If you read all the limb preservation programs there, vascular surgeons, podiatrists, infectious diseases, plastic surgeons, other specialists interested in this arena are all working together as a multidisciplinary team. So it's really unfortunate that in Ontario we don't have this. And I know that through one of my very close colleagues, Dr. MClSc in Toronto, who is a world-renowned, actually, vascular surgeon and has a special attachment to limb preservation. He's working with our podiatry team, and they're actually suing the health ministry for not allowing the podiatrists to basically practice. So I refer my patients to Dr. James Hill, who is a very well-respected and renowned podiatrist. He practices in the United States. He shares a practice with his wife as well. But unfortunately, patients need coverage for this kind of stuff because it is pricey, it is expensive. Other places that give patients, orthotics, I've seen them often in the wound clinic, and they come back, they spent $600, and now their ulcer is worse because they weren't properly offloaded, and it's just very frustrating because patients are spending out of pocket for these things, and it's not doing the job it's meant to do because a lot of these people haven't been trained how to properly fashion these orthotics. So whenever you want to send someone to somebody, you got to trust that they trust their work. And so I say, cough up a little bit if you can and go see somebody who's actually cares about you and will do a good job. And often Dr. Hill actually doesn't charge for the initial consult to help save the patients some money. So.
Any other questions from anyone?
I'd like to just maybe throw in a bit of a side spiel on venous care. In the case that presented on venous insufficiency was beautifully done and beautifully managed. A lot of wound care nurses and general practitioners are hesitant to put patients in compression when they have a venous ulcer, and nothing frustrates me more than this. I mean, compression and wound care is the standard of care for venous ulcer. If you do not put them in proper compression, you are providing substandard care, period. If you're worried about their ABIs, you get an arterial Doppler, and even if it shows, reduced ABIs, so what? If you don't put them in compression, their wound's gonna get worse, and now you're talking about rim loss for real because of venous disease. So yes, compression socks, compression stockings are different than compression wraps, compression garments. These are two completely different ways to compress the edematous limb. Compression socks have specific ABI requirements published by the Society of Vascular Surgery, which is, above 0.6, it's safe. Below 0.6, refer to a vascular surgeon. Compression garments have no published ABIs. If their ABI is 0.2, you can put them in a compression garment. And the reason for that is because when you look at what kind of pressure these compression devices have, there's something called resting pressure and working pressure. A garment, like a wrap, like an Unas boot or a Velcro wrap or something like that, that has a very low resting pressure. So it doesn't actually impair arterial flow to the foot. In fact, it enhances it. So there are many talks, on all the various venous symposia that I've attended in my practice so far, from renowned venous experts who say that when you put patients with mixed disease, arterial and venous, in a compression garment, even if their ABI is 0.3, that garment acts like an artificial valve and actually promotes arterial perfusion. Why? Because it's reducing things on the venous side, so it's allowing things to flow in from the arterial side. So if you're ever in doubt, just send it to Vascular, and we'll help you out and we'll deal with it. And I've had many conversations with the Lynn. I've physically gone to them and spoken to them in person and gave them presentation. Well, stop worrying about the ABIs. If I order it, then please do it. Like, there's no concerns. And they have their own specific concerns because of their own guidelines and this and that. So we're still duking it out together, but in a healthy way.
We also have another Q&A in the chat.
I can answer.
Perfect. Thank you, Harleen.
So I'm open to see any wound. It doesn't necessarily have to be PAD or diabetes. Like there's on the referral form, it says traumatic wound as well. So if that's, I'm open to seeing that as well. And then if they come to see me, I can refer them to Kunar Physio, and then directly, because it's through LLP, it'll be free, like free of charge for them. So that answers the question.
We also have a question in the Q&A. Any comments on, and excuse me here, pentoxifylline for PAD?
So yes, I mean, pentoxifylline is an adjunct. There's 2 RCTs that have been published about pentoxifylline. And both of them didn't show very drastic improvement in what's called pain-free walking distance, which is what their primary endpoint is. For CLTI patients, it doesn't do anything. But for patients who have claudication, it might improve their walking distance a little bit. The more potent or the better studied medication is cilostazol. And cilostazol is not approved in Canada for whatever reason. I don't understand it. But there are at least 4 different RCTs that have shown vast improvement in the pain-free walking distance with a regular use of cilostazol. So I don't routinely prescribe patients pentoxifylline because I don't see very strong evidence for it. It's just another pill and another drug to add to their long list of drugs already on. So instead of pentoxifylline, like we harped on before, just go for a walk.
Thanks, Dr. Sabalbal. There's one more just comment, not a question, but they say 100% agree with Dr. Maher Sabalbal that walking has many benefits for better health and walk is free from cost. So I just want to share that with everybody here. Any other questions? And thank you all for staying on later.
If I could, I'll just note, we had some difficulties with the polls today, and I do apologize for that. So we can't always see what's being posted, even though we're sharing it and being displayed on the other side. So we thank you for your perseverance to do that, and hope you forgive us for the technological issues there. Thank you.
If there are no other questions, please feel free to reach out to us. Again, my email is provided, and I will be reaching out to you all with your certificate of completion within the next few business days. So by the end of the week, you'll have resources, your certificate. And again, if you have any questions, you can reply back to that email, and I'll be happy to direct it appropriately.
Thanks, everyone.